I'm here to tell you that this procedure itself is very straightforward in the hands of an interventional pain physician. I think we still are early in our journey in figuring out the evidence, understanding which types of sacroiliac joint dysfunction, sacroiliitis really benefits. But I've been really honored to work with several companies, and I personally really like this particular approach because it's simple, it's efficient, and the patient satisfaction, at least in my experience, has been extraordinary. And this is the only posterior SI fusion company that is dedicated to the evidence. And when you come to the Aspen Society meeting in January in Las Vegas, there hopefully will be a data reveal regarding some of the early data regarding their pivotal trial. So looking forward to that. So without further ado, we're gonna just talk about the fluoroanatomy of the sacroiliac joint here. And everything about this procedure is really about making sure everything is lined up very well. So as you can see here, we're looking at basically an AP view of the sacroiliac joints. The anterior and posterior joint lines are those two lines on the sides of the screen, basically about the 8 and 4 o'clock positions of the fluoro circle. And I know you have a skeleton in the room there that Doug is probably next to. Really important that at some point today you take a look at the sacroiliac joints and understand the angle at which they're situated. They're a very complex joint. They angle outwards. And that outward joint line isn't a straight line like you might find for the knee. It's not a perfect sphere like you find for the hip. It is really sort of this meandering type of joint line. Perfect, so you can see it there. So what we're doing with fluoroscopy is trying to line up the anterior and posterior joints. So Victor is going to oblique, and usually that's anywhere between 20 to 30 degrees. And so we'll take a look at what that looks like. We're gonna focus in on the left sacroiliac joint here. And so Glenn, if you can point out the PSIS, that is a common point for a lot of the ligaments that stabilize the sacroiliac joint. When we do this procedure via the posterior approach, we are trying to basically get underneath or above the PSIS so we don't actually hit it, skive it, et cetera, because again, that's a good attachment point for a number of ligaments crossing the joint. So what you can see here in this fluoroscopic view is that there is a radiolucency in the midline of the anterior joint. Anterior joint's the one going basically straight up and down, basically from like 1140 down to 520. And the posterior line is coming across. And right in the middle of that X is that radiolucency. So this is what this tells us is I can basically take a K-wire Steinmann pin and introduce that into the radiolucency with relative ease. So we're gonna get started here. And what I'm gonna do is just mark out my landmarks here. So I'm gonna just take a point here. And then I'm just gonna draw a line that mimics that anterior joint line like so. And the length of that incision has to accommodate the widest instrument. That's just a golden rule for anything you're seeing today. Whatever incision you're gonna make initially just has to take on the largest diameter instrument. So as you can see here, if you wanna look at the camera here, this is the largest diameter instrument, which basically you would make about a 1-inch incision in order for us to accommodate that instrumentation. So I've got my line there. I'll use my 10 blade here, which is dulling from all the previous procedures. And we'll just get down along that joint line.
He does that. If you see a double joint, if you see something like this, and there's another joint over here, which is the farthest lateral joint? Is that the anterior or posterior joint?
It's pretty dull, yeah.
Anterior, because the joint is like this. As I sit here, my SI joints are 15 degrees like this, right? So the medial most is the posterior joint, right? So you need to get medial to the medial most portion to be able to get in here. Otherwise, the PSIS overlaps. I mean, the posterior iliac wing overlaps. You have to get in here past this ridge, or you won't be in the joint. And the biomechanical, so that's right there. So he's going medial, right along the medial line of the medial-most portion of the joint, which you know based on orientation, as I stand here, is going to be posterior. So he's getting.
And I can just feel, like hear Doug talking, I can just feel it just really sliding in here. So I'm just going to stand it up. Go ahead, Doug, keep going.
Yeah, and so
we'll take a look at a lateral here.
Got access to the joint,
Yep.
the K-wire. And then he's going to use a flat joint finder to spread that apart, and it's flat, and it's not sharp, and it's designed to go straight through the ligaments into the joint itself. And the articular portion of the joint, SI joint, is boomerang shaped, and the articular portion tends to be in the center and inferior portion of the joint. The fibrous portion of the joint tends to be superior. Perfect.
So what we see here is that my K-wire is cephalad to the sciatic notch. That's one of the areas you want to avoid. If you see the outline of the ilium, it is that large bone that's basically taking up most of the fluoroscopic window. And then you see the sacrum, that triangular, sort of like a toothpick, like coming down. And so really what we want is for our implant to overlay the sacrum and the ilium. That, of course, is the sacroiliac joint. So we can take this a little bit further in. It's really easy to move it. That means I'm well within the joint shot there. Okay, and what I'm doing here is I'm really trying to aim a little bit more cephalad, just because this is a single implant approach. There are some other products on the market where they use 2 different implants at different angles. Really, as you will see, I think, from our biomechanical study that's been published, or at least been accepted and will be published, there is good stability with a single implant alone. And as Doug was saying, our next step here is to use our joint finder and dilator, which is basically one instrument. So one of the reasons why I like using this particular product is it's a very simple hardware routine.
So as he does this, I'm going to point out anatomy to you. This right here is not the ala, it's the sacral body. This is not where he's working. He's working, the ala is out here. And this comes around here, and the ala goes right here. The joint comes all the way out here. This is sacral body. This is sacral promontory up here. This is S1. This is the vestigial disc. This is S2. This is the vestigial disc of S2 down here. And he's going to put this out into this space. If you're going to put an implant here, it needs to be at S2. It's a biomechanical center of the sacrum. If you put it overlying the body of S1 at this level, it will be the membranous portion of the joint. You will not get stabilization of that joint. The S1, ala, and the apposition, the joint that's closely opposed to each other, is way up here, anterior. And so he's got the joint finder, and he's putting in the working channel on top of that. And you can see it's lined up and it's opening up the joint.
So we're looking at that top tang here, and as you can see, as Doug just said, it's opening up that joint. And then we'll do a Ferguson view with a caudal tilt on the eyes, cranial on the source, to see the bottom tang. Yep, just like so. And we'll make sure that that bottom aspect of the tangs is in the joint as well. As I malleted, again, you can't really appreciate it as much, but as I malleted, I could just feel the give as I was going into the joint. So this is looking pretty good. I can do a little bit of a clockwise rotation to get that. Go ahead and take a shot there, Victor.
So what kind of a view is this? Does anybody know what kind of view this is?
Perfect. And we'll go back to a lateral.
This is called a pelvic inlet view, right?
And I'll advance this just a little bit further.
The other one is he's going to tip cranially. This will be a pelvic, well, if you tilt cranial, it'll be a pelvic outlet view. These are essential to know when doing SI joint fusion.
Yeah, those views are essential, especially when you're doing the lateral approach.
Yeah.
Perfect. So I'm just going to advance it a little bit further, and the reason why I'm going to do that, you probably can't see what I'm pointing at, but Doug can probably point this out. There's that rectangular window where my internal dilator is. Once I pull that out, I want the tangs to basically be within the sacrum, so I can advance just a little bit more. And by the way, I have a little bit of leeway here with cranial caudal tilt with my instrumentation, so I can make some adjustments. Notice that my bottom corner is getting close to that anterior sacral plate. So if I wanted to, I could just aim a little bit more cephalad here, shot here. So you see that. And I'll just go a little bit further. And you can start to hear that audible difference. I think that's great. So this is what's really cool about this procedure. You just take that all out. And now, just for giggles, we'll come back around. And Victor, if we can look right down this axis cannula. Thank you, sir. So now you can really see that my cannula is right down the joint. So just go straight down the barrel, my friend. Yeah, just follow that instrument, and then you'll be able to see. Yeah, perfect. So I wouldn't do this in a real case because I feel so good about how this is going so far. But again, for you guys to see, you can really get a good sense where that cannula is within the joint. Go ahead, and I feel probably a little bit more oblique here. Yeah, good. And take a shot there. And probably a little bit more caudal with your eye. Yep, shot there. So we're gonna look right down the barrel. Perfect, a little bit more oblique.
So you can see how wide the joint is. And the tines of this are expanding the joint. You can see
great.
Directly down there.
All right, so now, exactly as Doug said, we're looking right down the joint. You can see the anterior and posterior lines, the cross section, and we're basically going. So we'll go back to lateral.
You can see how wide the joint is here, right? Can you get an appreciation of the fact that he's opened that joint up?
What you see here is the decorticator. Doug has already mentioned this with the interspinous clamp. Decortication is important to promote fusion, autofusion within the joint itself. So what we're basically doing is excoriating the surface of bone to get that growth across the allograft.
So this will have 1 to 2 millimeters on the sacral side.
Everything is keyed with this particular instrument set, which is what I love, so you really can't screw it up as long as you put things in correctly the first time. I'm just taking some 4x4s, Ratex, or Laps, or whatever we got, just to make sure that as I mallet, this, you'll have some blood. You don't want it to spray in your face for style points, as Doug points out. So we'll just take this down.
1 to 2 millimeters of
there.
hyaline cartilage on the sacral side.
Beautiful.
On the ilium side.
And so what you're seeing here is basically what it would look like with the allograft in place. I want that rectangle of the decorticator to be within the sacrum, and that's exactly what I see here. If you look outside the body, there's a little bit of a gap. I could take it down a little bit further if I wanted, but I'm pretty happy with where I'm at. So we'll take that shot there. Beautiful. I'm not crossing the anterior plate. So this is really cool. This is a reverse slap hammer that you unscrew. I love this design. So I can just do that. Boom. Take my allograft, which is metal. This is keyed. So I'll take it like so. Again, 4x4 Ratex. Mallet, mallet, mallet. Good shot there. The allograft itself, if I can just grab some sort of one outside of the body, it is shaped so that it's tapered and also has ridges. So basically, as you advance it, you can't really back pull on it. So I'm going to bring it to the camera here so you guys can take a look. So you can see here, it's got ridges. It's got ridges right here. And so it's not going to pull out once you get it in. It's tapered, so this is the part that's going into the joint. And then the window inside, that is filled with the DBM. So that's, again, what's going to promote the cross links of bone that are going to stabilize the joint over the next 6 to 12 weeks. So this allograft is really clever. And so I can stop there. I'm pretty happy with how this allograft looks on fluoro. Another shot there. Yeah, so I'm right in the joint. So all I need to do, pull the green thing out, take the cannula out, shot there. Beautiful. And then we'll come back around to the oblique. And what we should just see is the allograft basically within the anterior and posterior margins of the joint. So there you go. Looks very nice. And then let's just do an AP view, Victor. So just bring that right to 0 degrees. Yep, straight AP. And then now what I want you guys to appreciate, and Doug can point this out on the screen, is the anterior and posterior joint line. And what you should see is that implant allograft basically between those two joint lines. Go ahead, shot there. And then periscope towards me. There you go. So you can see the crossover almost looks like a DNA or double helix. And then you can see the implant is between the anterior and posterior joint lines. So that's how I know, again, another confirmatory fluoroscopic view to make sure that I'm definitely within the joint.
Anterior.
One of the biggest criticisms about these is, that comes from surgeons, oh, you guys aren't even in the joint, you're off to one side. As long as you follow the appropriate steps, you know your fluoro really, really well, you will get this exactly where it needs to be. And again, the evidence is going to come out in the next year or 2 years where I truly think this is going to be an appropriate therapy for a lot of patients. Sacroiliac joint dysfunction and sacroiliitis is underdiagnosed. It accounts for 20 to 32% of low back pain. So there are a lot of patient candidates out there.
So this is tremendously underdiagnosed, agreed. The categories are anything that fuses 5-1, whether it be a 5-1 fusion or a long segment, anything that goes across that, fuses that, it's just a matter of time before the person has SI joint breakdown. The other category is primarily women with pelvic instability, mostly related to postpartum instability. It's not always the case. I did one on Monday, a 63-year-old male with pelvic instability unilateral. So don't know whether he had an injury or not. The history is not clear, but this does happen outside of that. The other one you have to avoid is seronegative and positive spondyloarthropathies. Will give you SI pain. That means it's not a contraindication to fuse this. They typically auto-fuse, especially the seronegatives. But these three categories will give you SI-related pain. And we see this very commonly. So how many SI joint fusions have you seen? Tyler started in July, and how many have you seen? 20 plus in 3 months. We do a lot. So we do a lot of SI joint fusions, primarily because surgeons love you. They want to make sure that you make your boat payments and your car payments and put your kids through college. So they fuse 5-1, leaving you to fuse the SI joints. And we also do a lot of some of our guys do bone fusions and the bone grafting fusions. And if those don't heal, they also have a rate of pseudoarthroses. And if they don't heal, then we'll go back and do additional SI joint fusion using whatever technique. How many approaches are there to the SI joint? Does anybody know this? How many documented approaches? I like the answer 3. It's not correct, but I like it because it's anterior to posterior, posterior to anterior, posterior lateral, and lateral based. There's 9 approaches that have been documented to the SI joint. And the ones I just mentioned, the posterior to anterior, posterior lateral, lateral, these are the 3 that we commonly will employ. So we do all 3 of them for different reasons. That's kind of beyond the scope, but posterior fusions, as Dr. Naidu definitely demonstrated, clearly works. It clearly works. So we have the best evidence, probably is a paper from Dawood Syed and Dennis Patterson, Eric Lee, that says you improve it a little bit over 40 points for VAS, 40.5 on the average, and you get 60% oswestry disability improvement. So that's a shot over center field fence. And these patients, you see them all the time. And it's just something that you need to put in your armamentarium to be able to do this. Regardless of what approach, it will work. And you need to have this as an adjunct. So the sequence goes injection, radiofrequency ablation, fusion. I found myself over the course of the years, I used to do a moderate amount of RF ablation of the SI joints. I've gone from doing a moderate amount to, we've done 2, since you've started. We do 10 times that many fusions. The reason why, if you do fusions, typically on the average, your pain will go, 60 points in the VAS, or 50 to 60 points, or 5 to 6 points in the NRS, and the oswestry improvement will be the same degree. It'll be 60 to 70% oswestry disability, and not only does it come down, it stays down. In the Vanna-Klotzer paper that follows this over 72 months or 6 years, the RF goes down, but then it comes back up. Then it goes down, then it comes back up. And I've gotten to the point where we just don't do that anymore. We know that if you have the appropriate patient selection, you fuse them, they stay good for a long period of time. Ostensibly forever. Questions, comments? Yes?
How many injections are you doing?
So the answer is, how many injections are we doing before we fuse? The criteria for SI joint fusion involves 1 injection, and I do 1. And if the criteria are, there's 6 physical examination tests, pelvic compression, pelvic distraction, sacral thrust, Gainsland's, Fortin's finger test is not one of them, although I did hear that. Patrick Faber, the figure 4 test. Pardon? That's an additional one. 3 out of 6. As long as these are positive, plus an injection test that has 75% or more reduction in pain, that's your person. Imaging doesn't make any difference, because you can have, the study came out, this is Cohen's study from a long time ago, that says once you reach the ripe old age of 35, 70% rather, of patients will have abnormalities on CT. So basically everybody has abnormalities on CT, degenerative that's not related necessarily to pain. So injection, 3 out of 6 physical examination test positive, and it makes sense. Somebody's had one of those 3 categories, that's your SI joint fusion patient.
I'll just add, for California LCD, we actually have this site that there's no fracture or tumor on imaging. And you guys have 2 injections.
So none of this applies to tumor, trauma, or spondyloarthropathy. These are separate categories, right? This is all just garden variety degenerative changes. Good point.
Ramo, 2 joint injections?
Yeah, for our LCD. We're Noridian. So if you guys don't know what we're talking about, LCD, this is your future. So for any Medicare patient, there's a national coverage determination on the CPT codes you perform, and there's certain criteria. You're definitely going to see this with epidural steroid injections come January 1st. This just came out from CMS. You have to follow all of the criteria for being able to get approved for you to do it, and you're limited up to 4 steroid injections per year. This is new. We've never had this really before. And then you have your local coverage determination. So what does Northern California think? What does Southern California think? What does Oklahoma and Texas? Are you in the same MAC? Yeah. So it just depends on where you are. So people do things in Louisiana way differently than we do in San Francisco, than we do here in Seattle, than we do in New York, just because we all are beholden to our local coverage determination. So he can do 1 injection. I got to do 2. I have to cite imaging. I have to do 3 out of 5 provocative tests, and then we're good to go. So it's important you document all of that medical necessity.
Awesome. That's awesome.